multifactorial, particularly in patients with advanced heart failure and advanced remodeling of the ventricle. So it's multifactorial, I agree.
Okay, thank you. Thank you very much indeed. Can we move on now to the last presentation from Professor Robert Dion, the mitral valve in left ventricular restoration.
We had that conference, we all decided to only talk for 10 minutes and everyone was
So it's a pleasure to be here, and it's a pleasure to be able to learn with my friends Lorenzo and John and Dr. Pagano and Jose Luis, and I really am really even more happy about the presentation of Robert Klaus. I hope that everybody of you, when you reach my old age, can have under your eyes such a rising star which is nearly your son. So Robert, I think not only your film was excellent, but the way you presented the thing made me very proud. Now, the mitral valve in left ventricular restoration is a controversial issue. It's a controversial issue because normally, if you restore the anatomy and the elliptical shape of the left ventricle, you should probably correct mitral regurgitation without doing anything on the mitral valve, and it's not really the case. It's the case in nearly the majority of the cases, but the problem is to know which one will not correct the mitral valve and which one will correct the mitral valve. To make this talk, of course, I had really slides and data from Lorenzo Menicanti, and of course from my ex-team in Leiden. And it is first important to know that the patient in the setup of left ventricular aneurysmectomy, there is a the patient with preoperative mitral regurgitation is a different population than the patient having the same big aneurysm but without mitral regurgitation. Because a patient with preoperative mitral regurgitation means that your remote myocardium outside the region that you're going to resect is already altered. Otherwise, you would not have a mitral regurgitation. And this is a slide based on the data of Lorenzo Menicanti, showing in his experience in San Donato the comparison between the group of patients with MR and no MR. And you see that the patient with MR, they have more failure, they have less angina, they have more arrhythmias, the wedge pressure is higher, the ejection fraction is lower, and the volumes are higher. So it's a different kind of population. Again, from Lorenzo and Marisa Di Donato, you look at the curvature method, the reconstruction angiographic silhouette, and this is a patient without MR, this is a patient with MR. The difference is not only that the base of the ventricle, which is in fact the spot of implantation of the posterior papillary muscle, is still working there, while it's not working here. You see the illustration here, but also the general silhouette here is more spherical than there. So not only there is a problem of the contraction of the posterolateral wall, but also there is a problem of shape. Now, if you look at the patient on this, the effect of this surgical ventricular regurgitation on mitral regurgitation, it's again data from Lorenzo because he has an enormous amount of patients. You see here in the in the group of 37 patients with preoperative at least moderate MR, no post-op MR in 84%, and 16% are still having MR after the operation. This is a group of patients where it did nothing to the mitral valve. So it's true that in the majority of cases, 84%, just by reconstructing the ventricle optimally, you can cure MR. The problem is that you do not know before the operation which one is going to be there and which one is going to be there. So we have to do something about that. And we should try to have a way to arrest a preoperative strategy. Now, in the literature, you find not so many publications based on that. The publication of John Conte in the literature shows indeed what Lorenzo had already demonstrated, that if you in the case of CABG alone, you have a very trivial reduction of MR pre and post-operatively, and if you add surgical ventricular restoration, if there is an indication for surgical ventricular restoration, you improve MR. The problem is that you do not know before the operation which one is going to be improved and which was not. At the end, at the conclusion of his publication, he says, decreased left ventricle volumes and improved papillary muscle orientation likely contribute to decrease MR after SVR. This is true, but again, the surgeon, before the operation, he wants to know which patient is going to be cured and which patient you should be treated separately. Now, Lorenzo and his team has concentrated on that and is doing his funny posterior, I call it funny, it's certainly very serious, the posterior annulus suture with endoventricular approach. He did that in 100 patients with mitral regurgitation, at least grade 2 before the operation. Look at the operative mortality, it is indeed another subset of patients. His general mortality is below 5%, but in the patient with preoperative MR, we deal with another type of patient. And in this case, in this patient, in this population, 21% of the patient had a preoperative MR. And if you look after the operation, 18% still have an MR after the operation and after this mitral valvoplasty. So it was certainly intriguing Lorenzo, because he said, why is it so? What should we improve? And what should we improve? He should improve optimizing the shape of the left ventricle and improving mitral geometry. And how did he do that? He started using the mannequin. And by using the mannequin, he was really hoping to not only address the shape of the ventricle, but to address the mitral shape and the mitral anatomy. And if you look at the mitral annulus, there is no difference using the mannequin, but look at the tenting area, there is already a difference. Look at the papillary distance. It is obvious on this graph that by doing a correct surgical ventricular restoration, you bring the papillary muscle to each other, even if you don't suture, and on the long axis and the short axis are also decreasing. But if you add mitral regurgitation, mitral repair on the SVR, you still have a better result. So here is Lorenzo is using not only an optimal reshaping of the ventricle with the mannequin, but is using mitral repair. And you see that mitral valve repair on top of the mannequin brings not only the mitral annulus, but also the tenting area. If you look at the mitral annulus here, you have, of course, a decreased with the mitral valve repair technique. And if you look at the tenting area, you decrease the tenting area. So not only the shape of the ventricle, but an action on the mitral valve as well seems to be very important, because you decrease the mitral annulus and you decrease the tenting area. Here you have optimized the shape of the ventricle. Here you have optimized the shape of the ventricle, plus add something on the mitral valve. So we're still not very further, because it should indicate, to obtain this type of result, that you would probably have to do a mitral repair every time it's a mitral valve regurgitation before the operation. Now, I'm still a little bit a part of the team of Leiden, because I'm included on the invitation of Robert to think about some of the developments. But the merit of what I'm going to show you, is this young surgeon is doing a thesis on ventricular aneurysmectomy, and he sent me the slides with a big thing like that, and Professor Dion only. And I think we should restore the truth. These slides have been initiated by Patrick Klein and, of course, Robert Clouds. The strategy that we have discussed in Leiden when I was there between 2000 and 2007 was to be a restrictive mitral annuloplasty when mitral regurgitation were more than grade 2. This grade 2 or more mitral valve restrictive annuloplasty, either preoperatively, if somebody had a mitral regurgitation grade 2 or more, preoperatively we would do a restrictive mitral, and also immediately after aneurysmectomy on the TEE on the table. So we would come off bypass if we had a doubt, maybe we cannot repair. If there was a mitral regurgitation right 2, we went back on bypass and put a ring. And we would like to show you the result of this strategy. What we did, you know the rules. I hope that you have read our publications. Theoretically, we want a 9 point of 8 millimeter. I don't care about the size of the annulus of the ring. You should, of course, take 2 sizes under what you measure in the length of the anterior leaflet, but the end point has to have a coaptation of 8 millimeter. Now, it is absolutely true in ischemic mitral regurgitation without aneurysmectomy. I must confess, and Robert has alluded to that yesterday in one of his talk, of his comment, it's not always the case when we have the feeling that we have a rearrangement of the left ventricle. I have to confess that sometimes we downsize by 1. But in general, we downsize by 2, and our endpoint, no patient go back to intensive care if he has not a coaptation length of at least 8 millimeter. This is the cohort of patients. There is nothing very surprising. You see that they are quite sick. You see the VO2 max, see the ejection fraction, and 44% of these patients had mitral regurgitation before the operation. And this is the management chart. 40 patients had a mitral regurgitation more than grade 2 before the operation, so they went, of course, for restrictive mitral. In 2 cases, it was not done. Why? Because one had a calcified posterior annulus, so we left it like that, and another one had a decrease of mitral regurgitation after the ventriculectomy. We had a doubt, it was probably just a grade 2, so we thought maybe we can get off without doing a mitral regurgitation, but on the postoperative TEE it was, and he went to the restrictive mitral group. Patients having no MR or MR less than grade 2, in principle no MR, but in 35 out of 52 it was like that. 2 patients had an increase of mitral regurgitation after surgical ventricular restoration, and I think Lorenzo was correct in his appraisal of this result. We were not using at that time yet the mannequin. I was using a condom, a very big condom. Everybody thought it was my condom, but it was a very huge condom. The advantage of the condom is that it is cheap. Don't ask me the price because I would blush. But it is cheap, but it doesn't give an elliptic shape. And if you measure correctly the volume, but you do not define the new apex, and probably using only a balloon, you would probably decrease and the longitudinal axis and the lateral axis, the horizontal axis, and so the sphericity is not improved. And I'm pretty sure that now that we're using the mannequin, probably we will have very few of these patients who increase the mitral regurgitation after the surgical ventricular restoration. This is the early and late mortality. This consecutive to our approach. You see that the survival at 2 years, quite surprisingly, is the same. There is no difference between the group with restrictive mitral regurgitation and the group without restrictive mitral regurgitation. Remember that these groups before the operation were not the same. You see that the operative mortality is much higher in this patient with necessitating a mitral annuloplasty compared to the people without annuloplasty, but you see that the late mortality is different, and at the end, at 2 years follow-up, the survival is exactly the same. If you look at the functional result between patient with restrictive mitral and patient without restrictive mitral, you see finally that the result, this is before the operation, the New York Heart Association before the operation, this is after the operation, and you see it's comparable. Even at follow-up, the number of patients in both groups are quite similar. Mitral regurgitation, again the same. You see that we are not the Cleveland Clinic, we are much, much better because we don't have 30% recurrence after 6 months, but I think you should either believe us, either come to Leiden. The mitral regurgitation is 0.5 after 16 months, and here as well. So mitral regurgitation, functional result, and survival are the same, and this is the consequence of our strategy. And if you look at the echocardiography, baseline, early postoperative, and 1 year follow-up, you see that the 1 year follow-up, nothing is still very significant unless, except the ejection fraction. But you see that the results are, this is really confirming what we saw in the previous slides. Before the operation, they are different. after the operation, 1 year after that, we obtain a good result, stabilized result in also the worst of the group. So in conclusion, I would say that concomitant restrictive mitral regurgitation for mitral regurgitation more than 2 pre-op or immediately after, if you have a residual grade 2 mitral regurgitation on the echo on the table, you should go back. If you treat it, you have a similar late outcome and absence of recurrent mitral regurgitation, despite the fact that the patient will